Hi, my name is Enriqueta Felip. I'm a medical oncologist working at Vall Hospital in Barcelona, Spain. So I'm going to summarize the most relevant studies presented here at ASCO 2012 dealing with biomarkers. First, Dr. Alice Shaw from Mass General Hospital presented the results of the clinical activity of crizotinib in advanced non-small cell lung cancer patients harboring ROS1 rearrangements. So now ROS1 rearrangements is a new target in non-small cell lung cancer. It is present in approximately 1 to 2% of the patients. Preclinical activity show promising results with crizotinib in cell lines harboring ROS1 rearrangement. And here in ASCO, Dr. Alice Shaw presented the results in 15 patients with ROS1 rearrangements. The characteristics of these patients were median age 54, 93% never smokers, 100% adenocarcinoma tumors. From these 15 patients, 14 received crizotinib. And in the study, they presented a 57% response rate, very similar to that reported in ALK-positive patients with crizotinib. So in conclusion, the conclusion of this study was that ROS1 rearrangement defines a distinct subset of non-small cell lung cancer patients, and crizotinib demonstrated activity in this group of patients. Another interesting study was presented by Dr. Capelletti from Dana-Farber, also from Boston. She presented the results, the discovery of another target in non-small cell lung cancer, RET. And RET is a target that we can treat with targeted agents. So the authors found RET alterations in non-small cell lung cancer tumors, again, in never smokers, adenocarcinoma histology. They show us that cell lines with RET alterations were sensitive to sunitinib, sorafenib, or vandetanib, and they show also that RET was found to be oncogenic. But in summary, from this presentation, RET is another target, and there are planned clinical trials with sunitinib in this subset of patients with RET alterations. Another important study here at ASCO was the analysis of a squamous cell carcinoma. Was a comprehensive genomic characterization of squamous tumors presented by Dr. Govindan. So in this study, the authors analyzed squamous cell carcinoma tumors. And they show that P53 was almost universally altered in these patients with squamous cell carcinoma. Another important target in a squamous cell was CDKN2A. They found deletion, mutation, and methylation in 72% of squamous cell carcinoma tumors, PI3K mutations in 16% of the patients, PTEN mutations in 15%, and fibroblast growth factor receptor 1 amplifications in 15% of the tumors. So again, very important results. Squamous cell carcinoma could be split in different subsets of patients based on genomic alterations. KRAS was also important during this meeting. Dr. Frances Schaeffer from Canada presented the results of the analysis of KRAS mutations in the samples from patients in the LACE bio study. So our patients included in adjuvant trials, the YAL trial, the ANITA trial, the Canadian trial, and the CLGB study. They analyzed KRAS in the samples from these patients. 1,500 patients were analyzed, 300 mutations were found, and Dr. Schaeffer presented that in this study, KRAS mutation was not prognostic for overall survival. They found a non-significant trend for benefit from adjuvant chemotherapy observed in wild-type patients, but not in patients with codon 12 mutations. But again, I would like to emphasize that this is a non-significant trend. And they found a very interesting observation, although the interpretation is limited by the small sample size. In those patients with codon 13 mutations, adjuvant chemotherapy was deleterious. in patients with a stage 4 disease, KRAS, there are no clear targeted agents. So we know now that KRAS mutations is present in 20–30% of the tumors of adenocarcinoma patients. And Dr. Pasijane presented an interesting study in patients with KRAS mutations. So this was a phase 2 randomized study analyzing a MEK inhibitor, selumetinib plus docetaxel versus docetaxel alone in second-line KRAS positive patients. So in this study, 422 patients were screened, 113 patients had KRAS mutations, and 87 patients were randomized to receive either the MEK inhibitor plus docetaxel or docetaxel alone. So interestingly, for this study, overall survival was longer for those patients receiving selumetinib plus docetaxel when compared to docetaxel, 9.4 months versus 5.2 months, although the difference was not statistically significant. All other endpoints were improved for the combination of the MEK inhibitor docetaxel versus docetaxel alone. So this is an important study and warrants further study for those patients with KRAS mutations. ALK, is approximately represents 5% of all our patients. These patients respond to crizotinib, but after 9–10 months, these patients progress. So during this meeting, Dr. Dovili presented an interesting study analyzing the mechanism of resistance to these patients, ALK-positive patients who progress to ALK inhibitors. So in this study, the authors performed a rebiopsy at disease progression in 19 patients. And they describe different mechanisms of resistance. And they divided into groups those mechanisms that they call ALK dominant and those mechanisms ALK non-dominant. In 50% of the patients, they describe an ALK dominant mechanism in the rebiopsy. In 31% of the patients, it was ALK fusion mutations. In 19% of the patients, ALK fusion gene copy number alterations. But interestingly, in this study, in 50% of the patients, when they rebiopsy the patients, they observe an ALK non-dominant mechanism of resistance. So they observe in some patients EGFR mutations and KRAS mutations. And this reinforce the need for rebiopsy in some of the patients with oncogene-addicted tumors after progression to EGFR, TKIs, or ALK inhibitors. Finally, Dr. Pike from Memorial presented also their experience using multiplex testing for driver mutations, again, in squamous cell carcinoma tumors. They presented data available from 52 patients with squamous cell carcinoma histology. Again, they observed fibroblast growth factor receptor 1 amplifications in 25% of the patients, PTEN mutations in 17%, PTEN loss in 11% of the patients, PI3K mutations in 8% of the patients, KRAS mutations in 2%, and DDR2 mutations in 2% of the patients. So in summary, I think this year during this ASCO meeting, very exciting results dealing with biomarkers in non-small cell lung cancer. We have two new subsets of non-small cell lung cancer patients, those defined by ROS1 and RED. We have learned that probably the molecular analysis should be performed not only in adenocarcinoma histology, but also in squamous cell carcinoma tumors. We have learned new data about the mechanism of resistance for patients with ALK translocations, and we have heard the results of a phase 2 study in patients with KRAS mutations with an interesting results with a MEK inhibitor. So, goodbye.